Our next speaker is a friend and a colleague who's at Carolinas Medical Center. This is Dennis Vrochides, and he really has overlaid an information platform across their HPV program, but most specifically their ERAS program. He is actually vice president of the ERAS International Society amongst multiple other formal ERAS efforts. So very much looking forward to his talk specifically on HPV ERAS. Dennis.
I do not have it. Thank you. Tom, Bruce, thank you so much for the invitation to talk to SAGES. And I would like to say good morning to everybody of you. I was asked to discuss about ERAS in HPV surgery, and only in 15 minutes. So since the Whipple guidelines are out since 2012 and the hepatectomy guidelines just came out, I decided to focus mainly on the hepatectomy guidelines. Now, if in the end of this short lecture we will have some time for questions, I could discuss a few things of how to improve implementation and compliance in the Whipple ERAS. Everybody knows here what ERAS is improvement of postoperative functional capacity restoration, mainly by eliminating variation in the perioperative period, by applying evidence-based multimodal strategies, and most importantly, by performing relentless structure outcomes audit, both for outcomes and compliance. Previously, you just heard about the important preoperative, intraoperative, and postoperative elements of every ERAS pathway, and the amount of healthcare professionals that they are involved, surgeons, anesthesiologists per item, nurses or ACPs, even information technologists. But if we want to come down to the nuts and bolts of every ERAS program, I would say that the hot subjects are fluid restriction, multimodal pain management, nutrition from day zero, and early mobilization. And the not items is the bowel preparation, the preoperative fasting, and the tubes. Do not use tubes. This is a slide that I like it a lot. The reason why I like it a lot is it describes, first of all, the ERAS care, how the recovery after surgery looks after ERAS care or traditional care. ERAS care is the red line, the traditional care is the blue line. The reason why I like this slide a lot is because it explains where the two lines from the ERAS International Society logo come from when Ole Lindqvist and Kim Fearon decided to do the ERAS International Society 10 years ago. Ever since many guidelines from the ERAS International Society came out, 9 until now, pancreas, as you can see, first was published in 2012. Right now, we are running the second revision of that. And liver guidelines just came out 7 months ago, and this is the focus of my today's talk. These are the 23 items. Obviously, I do not want you to read all of those. I would like just to point out that they are modeled after the colorectal ERAS items with 5 preoperative items, 9 intraoperative items, and 9 postoperative items. All 23 of those, they do not come from hepatectomy literature. The truth of the matter is that 7 items of those, they are inferred from colorectal literature, simply because there are no studies on hepatectomy. Also, the drafting process for these guidelines was a little bit different than the previous guidelines. This time we performed 2 discrete steps. First of all, ERAS International Society made a committee to perform literature systematic review according to PRISMA statement, and then it established an expert consensus conference for 7 internationally known hepatic surgeons. One of those actually came from here, from Houston, from MD Anderson. And the final recommendations were then made. In the systematic literature review, the hepatectomy references that were studied excluded patients with cirrhosis, excluded patients that had Klatskin's tumors, and excluded patients that they had additional simultaneous liver surgery, like colectomies, for example. Vascular resection was not an exclusion criterion. Initially, almost 2,000 records were identified and analyzed, but in the end, only 37 studies were considered for the recommendations. The type of manuscripts, these 37 manuscripts that they were evaluated, most of them they were randomized controlled trials and meta-analysis. The Access Consensus Conference, according to Delphi process, was actually web-based and in a 3-round process. And what I would like to point out is that of the 23 items, 7 of those did not reach consensus after the first round, so we had to do a second, and for 2 of those, we had to do a 3rd round so as to reach an agreement. One of those was the fluid management, item 22, which I'm going to discuss a little bit later. Let's go over one by one the items very quickly. First, the preoperative items. Preoperative counseling should be done in a very structured manner, ideally through classes. Preoperative nutrition is an important element. If we identify that the patient has lost more than 15% of his body weight the last 6 months, ideally the surgery should be postponed from 2 to 4 weeks so as to improve this patient's nutrition. Preoperative immunonutrition is encouraged. Preoperative fasting is absolutely forbidden. It should not exceed 6 hours for solids, and it should not exceed 2 hours for liquids. Preoperative carbohydrate loading is encouraged. Obviously, we do not advocate for preoperative bowel preparation and liver resections. As far as the 9 perioperative items are concerned, pre-anesthetics like midazolam should be avoided. Antithrombotic prophylaxis should be administered through either heparin and utilization of SCDs. Preoperative steroids is encouraged, but the truth of the matter is that it improves only biochemical function and it doesn't improve the outcomes. Antimicrobial prophylaxis, I would like to draw your attention to the skin preparation with chlorhexidine, not povidone iodine. And for open surgeries, we should be avoiding the Mercedes-type incisions. An interesting item is item number 11. ERAS International Society advocates for and strongly suggests performance of laparoscopic-only surgery for lesions that they are located in segments 2, 3, 4, B5, and 6. And if someone would like to do that in a robotic manner, that should be in the context of a trial. NG tubes should be immediately removed after termination of the procedure. Interestingly enough, ERAS International Society experts could not come to a conclusion regarding the drains, so no recommendation was made, although there is a tendency of not placing drains for anatomic resections that they do not involve biliary reconstruction. And of course, hypothermia should be prevented. As far as the 9 postoperative items are concerned, solid diet should be immediately restarted after surgery. Post-glycemic control should be performed with a regimented insulin therapy, not necessarily glucose clamping. An interesting item is the utilization of a mental flap in left-sided liver resections. Actually, this recommendation comes mainly from Japanese literature with 2 randomized trials suggesting that. We should not be utilizing bowel stimulation, and obviously the patient needs to be immediately mobilized after surgery. Another very important postoperative item is utilization of either epidural anesthesia, thoracic epidural anesthesia catheters, or TAP blocks, or wound diffusion catheters, or intrathecal opioids without preference to each one of those. But one of these 4 should be utilized. And also multimodal analgesia with avoidance of IV or PO opioids when the patient is on the floor should be utilized. Nausea and vomiting should be prevented with at least 2 antiemetics. Fluid management should be targeted towards euvolemic resuscitation with LR or albumin. And finally, audit should be performed systematically, not only for the complications, but also for the compliance. As I told you before, I'm going to dive a little bit deeper into item 22, the fluid management, because that was not an easy consensus to reach. So the item suggests that we should be maintaining CVP less than 5 during transection, and when we need to resuscitate the patient, we need to proceed with euvolemic resuscitation by avoiding normal saline or hetastrats. All these recommendations come from 3 different papers. The most important one comes from Jones, that was randomized trial of 100 patients, published in British Journal of Surgery in 2013. That in this paper, they utilized an individualized fluid management plan based on stroke volume variation and albumin 5% boluses. Utilization of CVP is a common practice currently after transection, and the resuscitation is guided by the CVP traditionally, together with some adjuncts like lactate clearance, creatinine urine output, and blood pressure. The guidance by CVP has been used since 1959, popularized 1962. However, we do know that it's useless in making decisions for fluid boluses, and it's no better than flipping a coin. And this is not said by 1 or 5 or 10 or even 20. This is demonstrated by 43 randomized trials. This is actually a meta-analysis of these randomized trials. 22 in the ICU setting, 20 in the operative setting, and even 1 in normal human subjects, in healthy human subjects. You can see the AOUCs. It's, as I said before, just flipping a coin. There is literature out there, recent literature, about utilization of SVV after hepatectomies. This paper comes, this for open hepatectomies, comes from Sloan Kettering, randomized trial, 135 patients, standard therapy versus goal-directed therapy during the immediate post-operative period, goal-directed by SVV. It showed that they decreased the amount of IV fluids administered by 30%. That led to a reduction of perioperative complications. Similar paper for laparoscopic hepatectomies, 90 patients, randomized trial, 1-to-1, similar concept, again, similar outcomes. Less blood loss with resuscitation based on stroke volume variation and less length of stay. Currently in the Carolinas, we're using stroke volume resuscitation in hepatectomy, utilizing the Ramsey protocol for the intubated patients and the NICE-Copper protocol, stroke volume alone for non-intubated patients. And actually, we are moving towards, we have a pilot study moving towards lineless SVV resuscitation because we do not use A lines for our stroke volume variation. We use it with cuffs on the fingers like a saturation monitor. What do we expect from the newly developed and published ERAS guidelines for hepatectomy? Well, these guidelines have been based on previous communications on fast-track surgery. And based on these manuscripts, on these publications, we can expect a decrease in length of stay, in complications, in cost, and a decrease in quality, and an increase in quality of life. In fact, there have been 2 meta-analyses until now for fast-track after hepatectomy, not based on the ERAS International Society guidelines, just fast-track surgery, revealed exactly that we have a decrease in the length of stay after application of fast-track pathways by 2.5 days and by decreasing the post-operative complications by almost 30%. One interesting outcome I would like to draw your attention to is the diffusion effect for hepatectomies. These data come from our facility. What exactly does this show? This is data collected for 6 months only, and that shows the effect that application of ERAS for Whipples had in our hepatectomy patients, that they were not at this point under an ERAS protocol. So when you see pre-ERAS, this is pre-ERAS for Whipples. Post-ERAS is post-ERAS for Whipples, but the outcomes refer to the hepatectomies. So you have a patient because all the patients, they are on the same floor. If you have a patient after a Whipples that you remove the Foley on day 1, you cannot have the patient from the hepatectomy removing his Foley on day 3. So we started doing that a little bit earlier. And that showed that we decreased the length of stay and the EBL by applying, without wanting to, ERAS principles to hepatectomy patients just because we have just implemented the pancreatic ERAS pathway. I also made a phone call to Dr. Demartin at Lausanne, who is the primary author in the ERAS guidelines for hepatectomy, and I knew that he was already been applying the ERAS guidelines for hepatectomy before publication, and he was he was kind enough to give me his data. So these are his data clearly showing improvement in complications and decrease in the overall length of stay. And that was done, very, very important. As I told you, audit of not only the outcomes, but also compliance is very important. That was done with auditing the compliance as well. So he started with a compliance of 40% and a length of stay of 10. And once the compliance was brought up above 70%, then the length of stay was lowered down to 8. So in brief, I do not think we have any more time to talk about improvement in compliance. Yeah, I think. In brief, we discussed about the drafting process, the general overview of the newly published hepatectomy ERAS guidelines, some items for euvolemic resuscitation, and the anticipated outcomes. Thank you very much.
Dr. Fuchshuber, question for Dennis?
Allowed to have put a question, I would like to. I'm from Pascal Fuchshuber from California, Kaiser Permanente. We implemented ERAS all the way to the hilt with on EPIC and everything. I noticed on one of your slides that you had a slight increase in readmission rate, even though it wasn't significant in very small number of patients. But I think it's one of the things in the back of our minds, and I've seen our hospitals pushing very hard to get patients out, sometimes forcing us to round early and get the patient out. Is there anything in the literature that you can tell us to make us think easy about the fact that there's really no increase in readmission by implementing these programs and pushing hard to get patients out early? Because you, even though it wasn't significant, I noticed that you had 3 versus 4 patients pre and post.
For the ERAS guidelines for Whipples for pancreatectomies, there is plenty of evidence in the literature actually suggesting that it doesn't decrease only the length of stay, but also decreases the readmission rate. I can give you data from our institution for the last 120 Whipples that they were done under ERAS protocol. When compared with the pre-ERAS 120 Whipples, our length of stay was decreased by 1.8 days, median length of stay, not mean, median length of stay, and readmission rate came down from 27.4% to 23.8%. So the same exact observations were done by many other centers, including Tom's center, I suspect. I remember we had a discussion about that. So for Whipples, for pancreatectomies, this is clear, that it doesn't decrease only the length of stay, but simultaneously decreases the readmission rate. About hepatectomies, the evidence is not out there, and the reason I'm saying it's not out there is because all the publications we have out are before the ERAS International Society guidelines, and there is a little bit, may I have two minutes for that? Thank you. There is a little bit of confusion about applying ERAS and applying real ERAS. When you apply real ERAS, according to the ERAS International Society standards, you need to have documentation of complications and also of the compliance. So if you do not say, okay, I do ERAS, out of the 23 items, what is your compliance on removing the Foley? I don't know. What is your compliance on removing the NG tube immediately after surgery? I do not know. What is your compliance for multimodal analgesia? I do not know. You say you do ERAS, but you don't, because there is plenty of evidence in the literature showing that compliance is associated not only with the post-operative outcomes, the immediate outcomes, but now in the colorectal world, evidence coming mainly from Sweden, from Olli Lindqvist group, that they are associated with long-term oncologic outcomes, long-term 5-year oncologic outcomes, disease-free recurrence outcomes. And the magic number of compliance that they are looking for colorectal surgery is 70%. Everything above 70% in all 23 ERAS items yields improved oncologic outcomes. Something similar, it seems that it will be true for other type of surgeries. For pancreatic surgery, it's not documented yet. We try to identify an association, but we can't with that. However, for the immediate postoperative outcomes, the magic number so as to start decreasing readmission rates, length of stay, and improving cost outcomes is again about 70%.
I think those are great points. I can just comment on our experience, obviously, in a cancer-only population, and we're extremely excited about the possibility that ERAS is going to actually improve survivals. And so we have some papers coming out in colorectal met patients for the liver that are basically going to show that ERAS is improving the actual oncologic outcomes. So trying to keep, thank you, Dennis.